Any question from the audience? Yes, yes. Buddy, can someone give him the microphone?
The problem is that if you mix two techniques, it's difficult to know which technique is working. But if you analyze each technique, you have 20% of failure. If you propose a technique for the patient would like 100% of success. And I think that, and it's by experience with a learning curve, we improve our technique. You see that I discovered the technique of the allograft this morning. Before you use allograft in one direction, now you use allograft in two directions, and you improve your technique. And I think that we have to analyze each technique, and you have to improve for the patient.
Yeah.
And I'm not sure that is a good way, but if it's not worse, it's good.
So I think the type of the graft, as Carla mentioned, is very important because the group from MGH and Brigham and Women, they published about comparison of 3 different techniques: SCR, latissimus, and lower trap, and they showed significantly better outcome with latissimus lower trap versus SCR. And they had 80% failure rate at that time. So, but again, they're all using dermal allograft. So I think the type of the graft is very important. And I really think also, other than the functionality, when we add all this technique, the question is really, are we really understanding the mechanics very, very well about what we're doing? Like, I just asked Thiru Mahata about, because honestly, even prior his presentation, he has an outstanding outcome. But a lot of his MRI, look at the MRI, the proximal migration is still there. So definitely is not containing the humeral head, but sealing the head, attaching the supra to, or infra to subscap, subacromial spacer, or like something just not to have an impingement, in addition to other factors. And we're trying still to learn them. For maybe over time I will do this combination. Up till now I haven't found the indication for it. Yes, Carla.
I'm sorry, it's just a comment because we're talking about the type of graft, and I think it's really important to pass this message. You showed the slide of the work of Patrick Denard and Steve Burkhardt. And they studied 59 patients, but they only did MRI on 20-something patients. So that 45% is of 20 patients. And this is a chronic problem in the studies in the US, is that you don't have MRI controls on this healing. You have Pennington's work with 88 shoulders, and they did MRI on 4 shoulders. And this is chronic. And this year, Burkhardt published continued study on the patients he contributed to Patrick Denard's study. It's a multi-center study. And he did the 2-year follow-up on his patients with human dermal allograft, 2 years clinical outcomes, but the MRI controls are from 1 year and not from all the patients again. So I'm sorry, here it's all the patients, but it's 1 year. So it's the 20 patients again mentioned in the same paper, almost. So, and the question about this, the signal, it's also for me very important because I do the analysis of the healing of the graft using the proton density fat saturated coronal cut. I've submitted a paper where I do a study on the 3-year outcomes, precisely to analyze this healing criteriously. And also there are no guidelines to interpret the healing of the grafts. This is I think is a question we all have to have in mind. We are comparing apples and oranges, as Bodhi Savoy once said. The type of graft really matters, and we don't have studies that compare at the same time point with MRIs, and we don't know how to look at these MRIs, and this should be discussed. And also with your technique, because we don't know how to interpret the healing with the allograft and latissimus.
Carla, I think also a big comparison when we talk about comparing apple to oranges, I really think it's the patient selection. It's a huge patient selection, because I mention always how often, how many of you have seen patient with a massive rotator cuff tear, slightly older, and he comes to your clinic doing this? How many? Why? Why can't they move fully? So we have still things we're not understanding very well in the shoulder. Gilles Walsh believes if the subscap is completely intact, the wrist minor intact, you rehab the patient, all of them should work. This is what he believes. And as you know, Gilles Walsh, we all respect him, he has a very high, and he has a number of patients. Not every patient, I think, the same. But the type of patient we are operating on are different. I just spoke to you, you said, if someone has an ER lag and they're complete atrophy, you don't do SCR. This is very important. The graft is very important. The selection of the patient is very important. The age is important, arthritis or not. So we have a lot of factors, I think, over time, I'm hoping we'll be able to kind of categorize them well to have our appropriate indication.
I think the problem is that if you respect patient selection, you have not a lot of patients. And to have an experience, you have to wait 5 years, 10 years. Because for me, for example, I select lower trapezius for teres minor, supra, infra. I receive a lot of patients, but I do 2 or 3 every year, no more. And is the problem, the first problem. The second problem is the publication. I agree with you, because I agree with your analysis of article of Patrick Denard, of course. But I think that in the future, for the tendon transfer on the patch, we have to do a multicentric study. I try to push Bassem to do a methodology to have the same patients and good selection of the patient on the techniques that we did. And maybe we can do a conclusion. Now it's impossible. It's impossible to have a conclusion because we have not a big series. We have many patients. You see that Bassem does with a good teres minor, with atrophy of the infraspinatus. This is not my indication of lower trapezius. But we have to do a methodology of over the world. And I think that a multicentric study regarding that should be useful for the patient and to clarify the indication.
I think that's very good.
Bassem, okay? Okay.
I think we're very good.
We kick Bassem out of the moderator table because they are almost ready there.
So, thank you, Philippe. It was very good.